All right, folks, we are right here at 1:30, so I think we should go ahead and get started. Welcome to today's breakout discussion on healthcare. We're so pleased you could join us today. My name is Ben Moore, and I serve as the Member Services Coordinator for the New Deal. Before we get started, I just wanted to quickly review how the discussion is going to work on our Hop-In platform. This session does have a max capacity of people who can participate on video and audio at any given time. So if you want to contribute to the discussion on camera, you can click the Ask to Share Audio and Video button, which will allow me to approve your request, and then you can join us on video and contribute to the discussion. If we hit our cap of people on camera and requesting to participate, I may need to move some folks back off camera who have already participated in order to make room for those who would like to join and share. You can also save me the trouble and do this yourself by clicking Leave your video participation once you've made your comment. And no worries, you can also always request to share your audio and video again if you have more that you'd like to share. A reminder that when you're not speaking, please keep your audio muted via the microphone button at the bottom of your screen. You can also double click a speaker on your screen to feature them and make them bigger in your view. While not on camera, I do still encourage you all to engage with those speaking on camera and others who are watching off camera using the chat box over to the right. Typing anything in the session chat is only visible to those who are here in this virtual room with us. You can also type @ plus someone's name if you'd like to direct a question or a comment to a specific participant or to one of our discussion co-leaders, but still put it in the public chat. You can also go to the People tab to privately direct message anyone at the conference, including those here in this discussion. So now I'd like to introduce our breakout co-leaders, starting with Kentucky State Representative Nima Kulkarni. Representative Kulkarni is the first Indian immigrant to be elected in the history of the Kentucky legislature. She has managed her own immigration law practice since 2010, helping others achieve the American dream. Nima has dedicated her time as a public servant to helping the most vulnerable Kentuckians. She's fought against harmful anti-immigration legislation, was the primary sponsor of legislation to reinstate the prevailing wage, and recently introduced the Kentucky Maternal and Project, which focuses on care for families, access to care, health equity, and mental health and incarceration. Thanks for being here today, Nima. Next, we have County Executive Matt Meyer, who proudly represents Newcastle County in Delaware. As county executive, he's cut government spending and introduced new technologies to make government more transparent and accessible. Most relevant to our purposes here today, he's also recently announced the expansion of the AmeriCorps National Health Corps program into Delaware. National Health Corps members will focus on the ongoing COVID-19 response, including vaccine programs and addressing health inequities associated with the pandemic. Looking forward to hearing about this and much more in our discussion today, Matt. Welcome. Next, we have Dave Kendall, who leads Third Way's health policy work with a focus on fiscal impact. As part of this work, he's creating a fresh approach to restraining healthcare costs, which combines traditional and behavioral economics to create innovative policy tools. Dave works to achieve universal coverage by building on the success of the Affordable Care Act, and he's helped in the fight against efforts to repeal the ACA, working on new ways to ensure that every American has affordable coverage and access to quality care. Looking forward to benefiting from your expertise, Dave. Welcome to the discussion. And finally, we're thrilled to welcome Erin O'Quinn to our breakout session. Erin serves as Chief of Staff to Congresswoman Schrier and will be able to provide a congressional perspective on the reforms and initiatives discussed here today. Thanks for joining us today, Erin. Despite the many devastating impacts of the COVID-19 crisis, it does present the healthcare sector with a powerful opportunity to innovate at a quicker pace and, in some ways, reinvent itself. With that in mind, I hope that this can be a wide-ranging discussion about what we have learned and the potential opportunities to build a new normal for our healthcare system. I want to encourage everyone in this room, whether a breakout co-leader or not, to participate in this conversation. We'll be recording the topics discussed here today and using them to shape future New Deal programming, so nothing is off the table. With that being said, I'd love to turn it over to Dave for some opening remarks. Oh, you're muted, Dave. I'm sorry.
Funny, they give you that your thing is muted, and then the warning covers the mute button. So it's like, sorry about that. So let me start just by taking us back to yesterday. where we remember the murder of George Floyd. His death will not be in vain. And thank goodness we're finally seeing the reality of race in America clearly. Another Black man died almost a year ago in a tragedy we may not remember. Darius Settles was 30 years old, living in Nashville, Tennessee, when he died of COVID-19. He had gone to the emergency room twice because he couldn't breathe. The hospital stabilized him as required by law and then sent him home. He didn't go a third time. He and his wife knew that they could face huge hospital bills because he didn't have insurance. But he knew he was in bad shape. He called his father, a pastor, and he died shortly after his father arrived at their home. Here's another part of the tragedy. Hospital administrators weren't making sure patients knew up front that a federal program was paying for the care of COVID patients without coverage. Nearly all young adults hospitalized with COVID survive. Would Darius be alive today if he had known that his costs were covered? Well, that's not even a question we should be asking. I'm just so thankful that we have new leadership in this country, which is committed to the simple idea that government exists to serve people. We need government to be a force for good now more than ever. And the pandemic has brought into stark relief just how healthcare is unjust and often ineffective. As of today, whites are 50% more likely to be vaccinated than Black people, and 40% more than Hispanics. The death rate for COVID for Blacks and American Indians is 40% more than for whites. For Hispanics, it's 24% greater. These horrifying numbers are part of a larger pattern of disparities. African Americans are twice as likely not to have healthcare coverage as whites, and Hispanics are 3 times as likely. This lack of coverage creates obstacles to care. Just like for Darius Settles, many people without coverage didn't know that they could get coverage for free. And the research has shown us that about 1/3 of COVID deaths are related to not having coverage. And that lack of coverage in a county by county analysis is strongly related to the number of COVID cases, because people without coverage delay seeking care when they start to feel sick. And that's also why racial and ethnic disparities exist for many other areas of healthcare. Maternal healthcare, cancer, diabetes are just a few of the areas where BIPOC have more health problems and get worse healthcare. So what's the solution? Well, it requires a lot, but one thing we can do is ask providers and health plans to report on disparities, support them when they make changes, and pay them more when they improve healthcare outcomes equitably. Congress is looking to enact a big initiative on healthcare disparities this year, and many states have their own initiatives, which I'm sure we'll be hearing more about from the other speakers. But one issue affects everyone, and that's the rising costs that is making healthcare unaffordable. America's concerns about costs have only gotten worse during the pandemic. 50% of all Americans are afraid of bankruptcy from healthcare costs, which is up from 45% in the previous year. And that concern has risen dramatically for people of color, who today 2/3 fear bankruptcy. And these concerns stem from the fact that Americans have seen their premiums, deductibles, and co-payments rise year after year. Third Way, which is a center-left think tank where I work, we're focused on capping people's costs so they can afford care. Capping costs means putting a limit on premiums and deductibles based on income. That's what the ACA started to do when it was enacted 11 years ago. This year, the American Rescue Plan put the cap on premiums for everybody who buys coverage on their own at 8.5% of income or less. Third Way is working with Congress to make sure that that cost cap becomes permanent and universal, so everybody can get afford the care they need. Cost cap is also a simple message that elected officials can use to show that they are addressing voters' #1 priority. It is also the key to controlling healthcare costs overall, because without overall limits, healthcare will be unaffordable for taxpayers. So I'm looking forward to our discussion about what other states and local leaders are doing in Kentucky, Delaware, and elsewhere. So and also from Erin Quinn. So I'll turn it back to you.
Thanks very much, Dave. Before we go to a local perspective, maybe Erin, we should pivot to you next to give us a quick. Any opening comments from you?
Yeah, thank you. Like Matt said, my name is Erin O'Quinn. I'm Congresswoman Kim Schrier's Chief of Staff. She's a pediatrician from the 8th District of Washington, which is a massive district, eastern Seattle suburbs, down to Mount Rainier, over the Cascades, and 3 rural counties. My background's public health and social work, and I've worked on the Hill for now 3 different healthcare providers turned members over the past almost 9 years. So it's been a really interesting year to be in that role. Our district was hit first. The first cases were just outside our district. And it seems hard to imagine now, but in those very early days, the vast majority of the country really thought they didn't have exposure or cases. And so for that very first COVID relief bill, we were really the front line, giving a preview of what challenges were to come and sounding the alarm places where we saw problems. And the rest of the country was more or less continuing on normally. And the very first week of March and end of February, we had people who were being told to quarantine, but they had no sick leave. Testing at that point was still a huge nightmare, where tests had to be mailed from the CDC to local health departments, mailed back. We now know about huge contamination issues, but those delays and inaccuracies were a big challenge. It was virtually impossible. Even if you knew you had exposure, you knew people in the hospital, you still couldn't get a test. FDA wouldn't allow the University of Washington to use their lab developed tests, and the hoops that they had to jump through were just entirely impractical. Elective procedures were already canceled very early relative to the rest of the country, while at the same time, without revenue, these hospitals were trying to add surge capacity. And at that time, telehealth coverage was limited or non-existent. And even if it were, so many parts of our district have no internet access. So video visits, even if they were covered, weren't possible. We found out the hard way that strategic national stockpile was full of expired stuff. So it was a whirlwind, and the federal government's not normally seen as nimble. And there's no shortage of challenges, but I think at the very beginning, it really demonstrated the power, and then again, more recently, the power that the federal government can have, that we passed 2 big, important bipartisan bills in less than a month. And that's unheard of these days in Congress. And that addressed some of the acute problems, but as all of you know, that as the pandemic continued, the response was tied up in politics and often delayed. And I think a few big takeaways stood out, and I'm excited to talk about them. To me, the decades of underfunding of public health were laid bare. I don't have to tell anyone here that. It's a cliche to say that you often, if public health is doing its job, you don't even know it's there. But we have a big opportunity now to fill in gaps and redesign the system to meet the moment with this new influx of funding. We saw some historic gridlock broken, that telehealth coverage, there's just been institutional aversion to changing or expanding. And now it's hard to imagine how we go forward without telehealth being a mainstream part of our healthcare. FDA approvals for public health use versus individual clinical treatment have still a lot of work to do, but has made a lot of progress there of how we think about approvals. And obviously the fast vaccine timeline. It's so heartening to see mainstream conversations that recognize the role of social determinants of health, that health is about a lot more than going to a doctor's office, to hear conversations about behavioral economics and meeting people where they are. And Dave touched on it, but it took a decade, but it really demonstrated the resilience of the Affordable Care Act. And we saw really smart, reduced barriers, like in the rescue plan, full subsidies for ACA coverage for people who are receiving unemployment assistance. We already know that the need is there, so why don't we cut out the administrative hurdles? And there's still more we can do. We know that millions of uninsured people are eligible for $0 coverage that we could enroll people automatically in. And finally, touching on that, I think one of the places that the new Dems in Congress, that Congresswoman Schrier is a member of, and the co-chair of the health task force, they've really led on the need for automatic stabilizers in federal programs so that politics can't hold up needed policy. Whether it's unemployment insurance tied to economic indicators, the federal reimbursement, the FMAP for Medicaid being tied to public health indicators, SNAP increases when there's economic downturns. There's a lot of ways that we can provide more certainty, legislate in a smarter way versus having arbitrary deadlines. So I'll stop there. It's been a lot. I'm excited to hear about all the innovative work you guys are doing in your communities, and we can help.
Great. Thanks so much, Erin. Matt, perhaps I'll turn to you next. As a county executive, how would you assess the performance of Newcastle County's healthcare system throughout COVID? What are some of the innovative programs that you guys came up with to address some of those shortfalls, and what comes next?
Thanks, Ben, and thanks as always to the NewDEAL leaders for putting this session together. It's really an honor to be here with other distinguished, very knowledgeable, experienced people who have a lot more experience in this area than I do. I'm a county executive, CEO of a county of 560,000 residents, including Joe and Jill Biden. I should mention he started here as a county council member, and of course, Senator Chris Coons, who I'll get to in a minute. But a little over a year ago, like a lot of you, we were sitting in a position we never anticipated we'd be sitting in, with a deadly virus, an invisible virus that was not visible to the naked eye in our communities, taking people who were spreading through asymptomatic individuals. We knew quite a few people, more deadly to some than others, but we weren't sure who was deadly to, who not to. We weren't sure if it was safe to go outside on playgrounds, play tag. Remember, I shut down our tennis courts at one point because we had reports that touching the fuzzy ball, they believed the virus could stay on the ball for an extended period of time. There was all sorts of information, misinformation, early stages of information. We had to make quick decisions. In that context, I sat down with my CFO in mid-March, just as this virus had descended on our community, just as people were starting to end up in the hospital. And I made a decision to do something we'd never really done before. And that was I don't think we've done in the history of our county. And that was to tap into our rainy day reserve fund. We have this fund of tens of millions of dollars that's been built up over a number of years. And I always kind of joke that why do we have this fund of taxpayer money if we never tap into it? And I said, okay, if there's ever a time where we don't want to increase taxes and raise additional revenue, now is the time. A few days later, in late March, the federal government passed the CARES Act, where we have population over 500,000. So we didn't have to tap into any of those reserve funds because we had $322 million from the federal government for our 560,000 people. And suddenly the conversation changed from where are we going to get the resources from to help our people to, okay, we have resources. How do we put this to work in the most efficient, effective way to save lives? The first thing we took on was testing. As Erin referenced, there was a shortage of testing. I think we all remember a time when you couldn't get tests anywhere. And if you could get tests anywhere, you usually had to be sick or symptomatic. We knew this was spread among asymptomatic people. And if you could get tests, it would take 7, 10, 12 days to get a test back. By the time you got the test back, it wasn't even worth anything because the virus had either left your body or spread to others. So we immediately set up, just working through the private sector, working primarily with Curative. We had a process, and actually I was talking to people in Korea and China and ended up choosing an American company out of Los Angeles, Curative, that happened to be in the early stages of one of the most successful testing operations, probably one of the most successful healthcare stories in the history of our country. And we have in the past year run over 500,000 tests at about 500 test sites run across our county, completely free, which I'll get to in a minute. Fast, efficient test sites. They gave quality, not perfect, but quality results. The next thing we did was we started to monitor wastewater. I encouraged the 2,000 employees working in county government to go out there and find new ideas. I said I wasn't sure how we were going to get out of this, but I knew there were going to be new innovative ideas that helped us get out of it, whether it's treatment, vaccine, or other information about the virus. And someone in our sewer department, we run the largest sewer wastewater department in the state, came to me, Mike Harris, kind of a mid-level manager, environmental manager, had read an article about a company called BioBot, 2 women just coming out of MIT, a grad program, who had been monitoring wastewater for 2 years, looking at opioids in communities. And they were starting to do COVID-19. So we contacted them. And next thing you know, within a week, they were monitoring 13 of our substations and measuring COVID-19 prevalence. Within about a month, we hired a local company to provide the data to the public. So our public health, our state public health could use it in allocating resources, doing contact tracing and stuff like that. And Senator Coons brought to my attention AmeriCorps. And I generally had the idea that we have all these needs and we have these shortages of people. And how do we take some of these resources to put these people to, there was a shortage of people to address this urgent health problem. And you had all these people looking for something to do who were at home, who were told to stay home to be safe. So what we did is, with Senator Coons' strong support and his extraordinary ideas, we kind of put two and two together and made five. I like to say we put together a national healthcare program that Senator Coons just referenced. And now we have a new AmeriCorps program that we're hoping just grows into the future because it's deeply needed. First, helping us to disseminate vaccines in our community, but in the long term, really starting to address some of those longer term health equity issues. Listen, for us here in Newcastle County, one of the most important lessons is something I learned. One other thing we did is we acquired a large hotel, as a number of jurisdictions did. A large Sheraton hotel had 291 rooms, and we turned it into the largest, most comprehensive homeless shelter in our state's history. We did it. We purchased it on December 1st. We opened the doors December 15th. And one lesson of operating that now for 6 months is that it's similar to what I've learned in healthcare, which is when you create a baseline, you create a floor. You say, we, the government, are going to provide the basics in 2021 for our people. We're going to stabilize your housing. We're going to provide on-site physical medical care from one of the local hospitals. We're going to provide you 24/7 mental health and substance use. You don't have to worry about. We're going to provide you high quality Wi-Fi for your kids. Suddenly, these individuals and families who had hundreds of problems when they walked in the door are seeing a lot of those problems go away and seeing their lives turned around. I think it's similar with healthcare. And I know a lot of people like David who've been looking at this a lot longer than I have and understand a lot more than I do. Understand that if you can just say, this is something, your basic, you don't need to spend 4 or 5 hours on the phone with 6 different insurance companies to get your basic healthcare taken care of. You shouldn't need to go to an emergency room and sit for 6 hours because your kid broke a finger or something like that, right? You should have primary care. I think the lesson is, in this urgent time when we had plenty of resources, we were able to deliver a lot of good to our people. And so now what we're having conversations about, when the times are a little less urgent and maybe over time we have a bit less money, how do we put those same principles into practice to address long-term problems like the tremendous inequity in health service provision?
Thanks so much, Matt. Super helpful. Nima, transitioning to you now, I'd love to hear about how your experience may have been slightly different than Matt's, legislating in the minority during COVID. What are the lessons that you've taken away? And definitely want to hear a little bit about the Kentucky Maternal and Infant Health Project.
Yeah, slightly different is an understatement. It was really something that I found to be disturbing because it was political from the outset. And so immediately wearing masks was a battle. And I am a legislator in Jefferson County in Louisville, which is a progressive liberal area, kind of a blue dot in a red ocean. And we had everybody, like there's a majority in our congressional delegation, in our state house, in our state senate. And there was just misinformation being spread about wearing masks, the importance of wearing masks. What does this virus look like? What do you need to be doing? People were immediately sort of geared to don't accept any mandates, don't accept any restrictions on your life, go about and do whatever you need to do. And so there was a lot of difficulty getting the right information to everybody on the same level. And we had a governor who from day one, or almost from day one, was there every day. So there is daily briefings, daily COVID briefings with Andy Bashir, and that was consistent. And that is something that really fostered a lot of trust, and because of the consistency. So people would tune in and say, okay, here's how many cases we have. Here's what you need to do. Any updates from our Department of Health and Services, any updates from our public health departments throughout Kentucky. And it's important to note, right, in rural Kentucky as well as in urban areas, this message went out. It was consistent, and I think it was a really good response, a really necessary response to all of the information that people were getting from a myriad of sources, whether it was online, whether it was from elected officials who should have known better. So that is something that I think really, really was crucial to saving a lot of lives in Kentucky. Just that one response, that one daily place everybody in Kentucky could go to get at least some level of information that aligned with CDC guidelines, that aligned with World Health guidelines. One of the other things that we focused on, and we went through the same testing issues as Matt and as Erin mentioned, lack of tests early on. I know that procurement was an issue because we had a federal government that was essentially pitting states against the federal government just to get these supplies, to get these tests, to get whatever equipment that was needed, PPE. And so that was, one of my first conversations with the guy who was in charge of this. And it was a similar story. We were talking to companies abroad, companies in Asia. And finally, I think we did also go with a procure in the United States. But all of that was up in the air. Where are we going to get protection for our healthcare providers? Who are we deeming essential workers? All of that became an issue and it's all against this backdrop of, do you really need to pay attention to this virus? How much attention do you need to pay? And so it was really important for everybody to hear, yes, people are dying. There are certain populations at greater risk, and we need to be mindful of that. I think that what we have really succeeded at is getting to a place where we're able to get the equipment, getting the message out, go get tested. And this became really, really important, especially in our immigrant communities, with our Black communities, where you're not necessarily going to trust a public health official that doesn't look like you, that doesn't speak your language. And why would you trust going and getting a test? You don't know what it does. You're not entirely sure what this virus is. And so it was really important to set up these mobile sites in communities where people could get tested for free. And having examples of people leaders in the community, right, immigrant communities as well as in the Black community, getting tested and encouraging others to get tested and following the guidelines, wearing masks, all of that was also a really important message that was that we had from early on. And I think that helped also save a lot of lives because at least you had some consistent messaging about what you're supposed to be doing. And certainly we followed through with that when we got to the vaccination part of this virus, where we are now. And so we have, kind of these super center sites. One is in the University of Louisville's, this giant parking lot in their stadium. And that's in my district. So that's been going really well. But people are going to get vaccinated, again, because of this consistent messaging that we had from day one about what the virus was, what are the guidelines, testing is safe, right? Go and follow the example of folks in your community. And so we're getting there in terms of the number of people vaccinated that we want to happen. I mean, obviously not as quickly as everybody would like, but we're doing everything we can in terms of getting the messaging out. So I cannot emphasize enough the importance of keeping politics out of health policy, especially. And this is I sometimes view it as a test run. There's plenty of other viruses that we don't know enough about and that could have much, much more dire consequences that we should be preparing for. And if this is how it happened in Kentucky, then it's going to be a disaster. And I'm just saying that because if you're not going to listen to health officials, to scientists, to the data, then there's a lot bigger problems that we have on hand. One of the things also that occurred was, you know, folks that were, sorry, can you all hear me?
You're still here, Nima.
Oh, I'm sorry. Sorry, it cut out for a second. Was the issue of folks that were incarcerated, right? So you'd asked about the maternal and infant health project, which, and I'll amend it a little bit. I wasn't the one spearheading it. It was my colleague and friend, Representative Lisa Wilner. And we were on a call early on, and this was not related necessarily to COVID. It had more to do with how do we talk about reproductive health care in Kentucky? That conversation has been dominated by one issue and one issue alone, and we did not talk about really the really awful rates, maternal mortality rates, infant mortality rates for women in Kentucky. And so this is essentially a slate of 21 bills that we came up with that address some of those concerns, including women that were incarcerated, expanding Medicaid coverage for midwives and doulas, making sure that there's postpartum coverage that's expanded past 60 days, mental health care for women, and you know, more along those lines. But I think that's something that's crucial also for Kentucky. We have the third highest incarceration rate for women in the world. I mean, that's a statistic. That's one of the lists that we top that we shouldn't, we want to be at the bottom of. But of course, all of that impacted COVID, and that's true for immigration detention. It's true for people that are just stuck in jail. And I think that's something that we tried to respond to as quickly as we could as well, recognizing that these are populations that are not being well served. And I think our response could have been better. I think everybody has learned from this this experience, but it's a disparity that exists in Kentucky, and I'm sure in different communities throughout our country. But I think it really brings to light how different something like a global pandemic impacts different communities where they are, whether you're in rural Eastern Kentucky, whether you're in a jail in Jefferson County in Louisville, whether you are in an immigration detention facility in Northern Kentucky, whether you're just a person that's in your community that is not paying attention to CDC guidelines and making sure that nobody around you is. It is crucial for us to have really solid messaging around public health and making sure that that messaging is consistent. I think that's something that was a really strong takeaway from our experience in this pandemic.
Thanks so much, Nima. Folks, I just want to remind everybody now that our breakout co-leaders have had a chance to make some opening statements, please do feel free to jump in here with our last 30 minutes. You can either do so in the chat, or you can request to share your audio and video and join us here on screen to join the discussion. One thing that I did want to go ahead and just make sure that we touched on here is a very prescient issue right now for all of us, which is, of course, hesitant communities in terms of the COVID vaccine. I'd love to hear from Dave, Erin, Matt, and Nima about what you guys are seeing specifically in your own communities, because every community is obviously unique, but also, you know, what are those cross-cutting strategies that tend to, in terms of convincing hesitant communities to take up the vaccine? What are things you're seeing, and what are some strategies that those who are watching here can take home to their own communities?
I'm happy to go first by default. Yeah, I think that there's, you know, one of the things that we learned first off was it wasn't really hesitancy, it was poor targeting. I mean, we targeted initially for the vaccines people who are older. Well, Blacks and Hispanics have a shorter lifespan, so we weren't hitting. They weren't even getting it because of that. So I think we've worked through some of those problems, but we still have a huge disparity issue. And yeah, so the things that are working, you know, are varied. I mean, it's everything from employers giving sick leave or other incentives or free donuts. I love the free donut thing, to people as a way to make this a fun thing. I mean, it should be getting, you know, we should be celebrating a vaccine because it means we can go out and do more. But you know, that those kind of incentives are becoming more important as we get to people who are maybe a little more reluctant or a little just more. And it may not even be reluctance; it may just not be the availability of time. I think micro targeting on social media those kinds of campaigns that, frankly, Republicans have used against Democrats and other cases, Russians have used it. Well, we can turn that around and use that, constructive way and have the kind of micro targeting that gets to people who are vulnerable and who have a limited amount of time. One of the stories I've heard is like, in order to reach single moms who are working at home, you need to reach them at 10:30 at night, because that's when they're online, and that's when they're checking on their next day. And so you can do kind of that kind of market targeting. So there's lots of, I think we just have to, I've seen a lot of creative things, and I'll post just something I've been meaning to share from the Hispanic Health Alliance that is a good resource as well. Let me put that in the chat.
There are two other things that I'd add, David. I think that was good, and we're trying to do a number of things, and we're certainly not perfect here by any measure, but one is making it really convenient. So finding where are the people who we need to get, who are under vaccinated, where communities are, and just make it super easy, bring it to them. And another is getting influencers in front, getting influencers to sort of spread messaging from people that people trust. A lot of times people don't trust the county executive. If I go to my mom and ask her to do something, she doesn't trust me. If you go to my dad trusts me a little more. Everybody has people that they trust, and you find who are those influencers in the community. Sometimes it's big movie stars, and sometimes it's just the guy who organizes the basketball game on the street or whatever it is. And make sure you get in front of them and make the ask to see if they'll either get vaccinated in some public way or help to disseminate messaging.
Oh no, go ahead, Erin. I was just unmuting myself. Okay, I'll add to that. I think it's something that I didn't touch on in my previous comments, which is the importance of broadband access. And I know Erin mentioned it, but in Kentucky, you have a lot of areas that don't have basic internet. And so we ran into this issue when we shut down our schools, and we were relying on the internet and assuming that children in their homes would have internet enough to do their homework or to do research, or at a basic level. We're not talking about super high speeds here, but that includes also who has access to telehealth, who has access to mental health care, who is able to get the most up-to-date information. And so what we found is going to people where they are is really the only way to be effective in Kentucky. And I think that's true in Louisville as well. So we have pockets of Louisville that also have just as little access to broadband as you would in a rural area of Kentucky. And I think that is something that we have to really focus on when we're moving forward with any public health initiative, including vaccinations or during the next pandemic or whatever it might be. I think we've seen how crucial access to broadband is, and how lack of access to it can have really devastating effects in your community. And I agree with Matt. I mean, in Kentucky, we have a definite level of hesitancy to get tested, hesitancy to get the vaccine. People don't trust elected officials. They might trust their parents. I hope so. I hope they trust their community leaders, because that's who we've been asking to go into their communities and say, look, go here down the street, there's a clinic that has vaccines. Go here, there's a mobile vaccination site. I've done it, and we have, we use social media where we could, but it really is kind of a boots on the ground effort. So people can see you getting vaccinated, see you following guidelines. And if it's somebody that they trust, hopefully they will follow suit. But it's a little bit of a different story here. But I want to just reiterate how important it is to have equal broadband access in a public health context, because we really need to be able to survive these things together.
Go ahead, Erin.
I was briefly echoing all of that. Couldn't agree more with making it the east. And we're seeing in our biggest county, in King County, Washington, virtually all of the middle schools and high schools are doing on-site vaccination, where parents can you sign the permission ahead of time, but you have all the kids right there, and it makes it easy. And we know that, I mean, COVID vaccines are an uncharted territory and different dynamics than most vaccines, but we know the vast majority of people are not entirely anti-vaccines. There is a small population, you're not going to change those people's minds, but the vast majority of people with patience, with it being the easy option at sporting events, at workplaces, at schools, and patient answers from physicians, that most people will get there.
Thanks so much. One thing that dovetails nicely with what Nima was discussing is obviously telehealth, something that became very mainstream throughout the course of the pandemic. We've seen evidence to suggest that telehealth has reduced costs for some patients, has reduced no-show rates, but also there are significant concerns around patient data and other aspects of telehealth. So getting all of your opinions on what parts of telehealth are here to stay. Why is it important that we codify some of these changes that we've seen throughout COVID? And where do we need to pump the brakes on telehealth expansion, or do we?
I'm happy to take the first shot at this one. So yeah, I mean, it was long overdue. I mean, it's like, hello. I mean, we do everything else virtually in our lives. Why doesn't healthcare do this way as well? There's reasons for it. We don't need to spend a whole lot of time going back over, that history, but we're not going to go back, as we're moving forward. So I don't think we need any restrictions on it. I think we need to just use it fully. The benefits are going to be just dependent upon how people want to access it. I mean, if we can trust people to determine how they best can access healthcare, I mean, that's pretty straightforward. So, and in terms of the privacy, I think that's overstated. I mean, we do overwrought worry. I mean, we have good laws that protect against people's privacy. The bigger problem is how do you get the data out of these secure systems so that they can be shared with other providers as you move from provider to provider, especially with telehealth, where you may see one provider in one state and one day, and then another state in the other day. So making sure that data is portable is, I hate to say this, but it's one thing that the Trump administration actually did a good job of. They actually put some new rules in place that will make, based on Congress's actions on the 21st Century Cures Act, to make the healthcare information more portable. We each should be able to have access to our own information, and it should be made available. On my phone, I can get my health records, and it's stored on my phone, and that's something that we should see more of. So, just a few thoughts.
I think thinking through how we can keep a lot of the positive things, but also think through some of the equity implications that a certain population has really been able to benefit from telehealth and use it, and that's great. And we shouldn't, I think we should, within reason, keep that as much as possible. But a whole lot of people are not plugged into telehealth. Telephone visits have helped, and for certain specialties and visits, that's really important to keep. That you can get a lot of information for certain visits on a telephone. One of our towns has set up a telehealth room at the library, and I think that, like, thinking through some creative ways it might be 3 hours to get into the city to an appointment, but 15 minutes to your library that has good broadband, someone who can help with the device if you need technical help of just getting on. Private. I want people to have the ability to have expanded mental health access, but if you're in a crowded living situation with a lot of people, it might setting. So I think thinking through some access ways to telehealth.
Matt or Nima, any comments on telehealth specifically in your own communities?
Yeah, I don't know, Matt, if you want to go first. I saw you did yourself.
Go ahead, Nima.
So I just very quickly want to say, no, I don't think we need to pump the brakes at all on telehealth as a bottom line answer. I think that, like with most issues, the pandemic has brought into stark relief the haves and the have-nots, the people that can access things, the people that can't. Kentucky has some of the highest child poverty rates in the country. And so we cannot assume that they are, and they have a lot of need for some of this mental health care and access to food and things like that. And being able to do that, you have to have continuing access to some of this stuff. And I'll go back to the broadband issue. But I think when you talk about issues of equity, we don't also always think about things outside our own experience, people who don't speak English, people who don't trust, the sites that they're trying to go on, people that just are not, technologically savvy. And we have a lot of those populations that we really have to work a lot harder to access and to explain and to really get involved and get engaged on this specific thing, to where telehealth is something they trust, telehealth is something they can access, and it's something they can really benefit from.
Thanks. It's hard to follow those three. That's a lot of good ideas. I actually was taking notes, Erin. If you come to Delaware in a couple of weeks and see telehealth rooms in our largest library system, you will know why. You can take some modicum of credit for that. So thank you. I mean, listen, I think it's really exciting. I think the world accelerated very quickly into the future, in the past year, and there's some exciting aspects of that. One good thing / concern, I was a teacher before I ran for office, and my teacher friends, we were talking the other night about sort of the world that's evolving. And a friend of mine was telling me in her class, there aren't really sick days anymore. She says there are near death days, that if you look, like now their school is almost entirely in person, but it's acceptable if you don't feel well, or having a bad whatever, can't go to school or have a doctor's appointment, that you just do virtual. And then she said there are people who are absolutely in dire shape who don't go. And that's sort of a good thing in a way, that people who otherwise pre-COVID were not able to participate in activity. I imagine that's true of medical appointments as well. I can now take a medical appointment from my office, and which is great and saves me a lot of time and enables me to go to the doctor and engage in preventative care much more than I would before. And that's available to a lot of people, but of course, not everyone. A concern with that is just the way education, there's a lot of evidence emerging that in-person learning, there's no substitute for it compared to online learning. There's a fear that there'll be almost like a class system, where there'll be a healthcare system where you go and can afford sitting with a doctor in person, and there'll be another healthcare system for people who just get a quick sort of distracted medical practitioner online. So we just got to watch that and make sure that this is used as an opportunity to enhance our public health system, and not to decline its productivity.
That's really interesting, Matt. Thank you. A little bit to our question in the chat, and maybe this can begin our rundown towards the conclusion here. Obviously, I don't think any of us right now want to think about a future pandemic after what we've been through last year. But one of the things that last year has also taught us is that we don't have the luxury of not thinking about a future pandemic. So as has become tradition, perhaps Dave, we'll start with you. How does the experience of the past year help us prepare for a pandemic in the future?
Yes, and let me also just agree with what David McKissick just said in the chat as well, about we need to be careful about virtual medicine, because a lot of people need to have that, as you were saying, Matt, and others, it's like we need to have that personal connection. There's a tradition of laying on the hands that actually helps heal people. It's a proven scientific fact. So it actually helps to have that physical connection. So yeah, going forward, we're going to probably need to do the institutional things like a 9/11 style commission. There's a bill in Congress to do that. Hopefully that'll get attention once we kind of really start to see the vaccination rates go way up and really start to put this behind us. But yeah, Ben, you're right. Like, we just don't want to think about this going forward. So there's a bunch of things that we need to do for other reasons that I think will help. We need to build resiliency in our communities. We need to build support for our public health departments and what they do. We need to increase trust in science. We need to have leaders who respect each other. And so, I mean, I think a lot of the kind of broader societal changes that right now we need, will help us in general. I don't think we're very good at preparing for disasters. And we had a plan out there, it was buried and the Trump folks disbanded it. And so we're not great at that, but building resiliency in our communities and our individuals as individuals, that's to me the most important thing we can do.
Thoughts from you?
In a very narrow response to a broad question, I think we've really spent the most time testing. I think it's from the very beginning when South Korea was doing drive-through testing and we still had virtually no testing, to the summer where there were 2-week delays to get your test results back, and there were rapid tests that could get you accurate results in less than 30 minutes, but were being held up in the approval process. That's really where we've put a lot of our energy, is both kids under 12 to get back to some sense of normal in-person school in the fall. I mean, hopefully in September, we'll see a lot of them be able to be vaccinated, but we still need testing, and we still need, hopefully there won't be, but there will likely be additional contagious variants that vaccines might not be as effective against for this one pandemic. And the technology is actually really simple, of being able to just swap out the antibody that you paint onto the test strip to detect whether or not the virus is present. And so how can we have that infrastructure set up so that everybody can have tests at school, at the workplace, at the airport, for whatever our next virus is, and for right now, for COVID.
And I'll just add very quickly, I think we're at a very exciting but also very dangerous juncture. I think this pandemic has really made it easy for us to see where the gaps are, where our weaknesses are, where we need to focus. And I think looking at India's response to a variant and seeing how there has been a lack of testing, a lack of seriousness given to this variant and who gets access, right? So you already have the situation where if you have money, you have access, and you have so many millions of people that just have no chance. There's just no way for them to get help, which puts everybody in danger. And in a country that size, that's a real problem, and we can clearly see the results of it. I think what we have to be really careful of and mindful of is when it comes to public health policy, we don't let capitalism be the driving force here, because there's an opportunity for that to happen when you start virtualizing everything, when you get new technologies, when you start relying on those new technologies in getting healthcare to people. And I think we've got to be really vigilant against that. I think there's opportunity here, but I think there's also a lot of danger, so that we just need to be mindful of and make sure that we have access for everybody in mind and as a priority, whether we're dealing with variants or whether we're dealing with any other public health crisis in the future.
Yeah, I think Nima's point is a really strong one. After the pandemic started, when everyone was scared, including me, we didn't know what was coming next. We didn't know just how lethal and dangerous this was. The story out of Wuhan and then Italy and then New York City were horrific. My main talking point was, hey, in an incredibly divided time, this is a virus that attacks all of our bodies. Doesn't matter what country you're from, doesn't matter how much money you have, rich, poor, women, man, old, young, it attacks, and it's lethal. I think we learned pretty quickly to stop saying that, because as it turned out, not only did this virus serve to divide our country in so many ways, but it did not impact all communities equally. It really, while the virus, I imagine, didn't have biases in and of itself, it attacked vulnerabilities and inequalities that were pre-existing in our society. And so long as those inequalities still persist, when the next one comes along, we're probably going to have a lot of the same problems. So that's a lot of what we're talking about now. How do we take the stimulus that we have and all of our policy making and look at all sorts of things that were totally off the table, people living in places that are substandard, and giving them a more appropriate place to live, or providing some opportunity or aligning incentives so that housing developers can develop really quality housing. And like we talked about, making sure there's quality, true quality health care for all, as Senator Coons was saying earlier, some floor for everyone. So, you know, if you, as Nima said, capitalism, some aspects of capitalism failed us. They fail us in crisis. And we need to be able to very quickly identify, because in those early moments of a pandemic or any crisis, making quick decisions, getting good information is a matter of life or death.
Great, thanks so much. Just want to give one more chance to our participants here. If anyone would like to hop on video with us and ask one final closing question, or to pose one in the chat, you're more than welcome to do so. In the 5 minutes or so that we have left, I did just want to give one more opportunity for some closing comments, whether it be on how we can build this next normal of our healthcare system, how we can better address unequal health outcomes, and or anything else that you all would like to leave us with today. Dave, I can start with you.
Well, let me go real narrow on this. I went for Nima as well as others. There's a really great program in Kentucky that needs to be called out, I think, which is when somebody applies for UI, unemployment insurance, they get about healthcare coverage from the Medicaid office. And if they open that email but don't the application, they get a call from somebody in the Medicaid office saying, "Can we help you with coverage?" And they walk you through the application. And Kentucky's had a phenomenal enrollment period now during the open enrollment period that President Biden started. And so that's just a great example of how government can be personal and deliver real results for people.
Oh, you're muted.
I think by this time I get the hang of it. Thank you for bringing that up, Dave. I think it's so crucial to point out, you know, how important the expansion of Medicaid has been in Kentucky. People just having health care and now expecting to have health care. I don't think you're going to be able to take that away from them. And I think that's something that we should view as a victory and as a way to, I mean, again, this idea of trust and accountability and transparency in our healthcare system. I think it's crucial to understand and to really perpetuate this idea that healthcare is a basic, fundamental, universal human right, that we all need to be able to live healthy lives, and that there's a lot of different issues that feed into that, whether it's food, whether it's clean water, clean air, and I think that is something that we need to use this idea of, okay, now you have healthcare, what does that mean? To send some of these messages in the future. So, and again, you're right, Dave, that personal touch has been really important in Kentucky as well, not only for providing examples for testing and vaccination, but also for people who have been isolated, right, for a year and a half. And it's been really difficult for people who live alone, for people who are unable to see their families due to health conditions. So I think that is a crucial thing that I think hopefully we can expand to other agencies in Kentucky as well.
I think it's my hope going forward that we are able to see from this that more generous, that I guess kind of going back to the beginning of that healthcare is about so much more than just an exam visit, and that our social infrastructure, some of the temporary increases that we are able to make the child tax credit permanent, make some of the increases in SNAP permanent, that if we want to have a healthy, well-functioning, prepared society, that we need to make sure that people are not worried about food insecurity and housing, and really addressing a lot of the social determinants, and as much as possible, finding a way to build in some automatic ways to trigger those programs so that politics can't hold up necessary help, and we don't find ourselves back at desperation like we saw throughout this past year.
Yeah, and let me just close it out with what Davey wrote in the chat. What I think is really important, we talked about a little bit in the beginning, David, is behavioral health and mental health. How initially this really was about physical health and the threat of a virus, and over time, as we talk about it more, we're talking about health more holistically. And I just hope that the same progress, historic progress that's been made in terms of attacking viruses using mRNA and things like all these great new technologies, I hope there are similar leaps forward in behavioral health and mental health. And we as elected leaders are committed to investing additional resources to make that happen.
Great. Thanks so much, Matt. I want to especially thank our featured co-leaders here today, County Executive Meyer, Representative Kulkarni, Dave, Erin. Thank you guys so much for joining us here today, and to everyone who joined to participate in the chat. We will start back over with our closing plenary at the stage over on the left of your screen at 3 p.m. Eastern. In the meantime, if you just can't get enough of this great ideas summit, feel free to click on over to the networking tab and meet some of your other summit attendees. Thank you again, everybody, and I hope to see you all soon.
Great job, Ben. Thank you.
Thank you.